Hi, Diane Wist, CEO of Violet Daily. Today I had the privilege of sitting down with Dr. Jack Kessler, a world-renowned scientist, specifically in the world of iodine. Also, the scientist and developer and formulator of what we know today as Violet Daily. Today we take a walk down memory lane for him, all of his work in the world of iodine, but specifically in the development of the breast health pill Violet Daily. Sit back and enjoy this conversation. I know you will as much as I did. Today we're joined by Dr. Jack Kessler, a world-renowned scientist, specifically in the world of iodine. And rather than go into a whole lot of me introducing him, I'm going to let him introduce you. However, he is for me, an expert in the field, but also my mentor and my friend. Jack, tell us a little bit about the work you've done thus far, because you continue to work in the field of iodine.
Oh, it started back in 1982, actually. Someone asked me to invent a toothpaste, and that led to an enzyme-based method to form molecular iodine, which led to a number of SBIR grants in various areas, anything from hemodialyzer disinfection to poultry egg disinfection. And eventually it became a little bit too much to work full time and take care of and support that. In 1990, I started the first company called Symbolon, and we worked there. And that's actually where Iogen was birthed. Eventually, they had been a prior effort to commercialize the work of William Gent, a Canadian physician who treated like 10,000 women from all across North America for clinical mastalgia. And that effort was done by a company called Patheon. Unfortunately, the route they took for the dosage form was not the correct route. And they had problems with the FDA leading up to their phase 3 trial. And by the time I had returned home, I realized a better way to formulate a stable oral dosage form of molecular iodine. And so we did that work in the laboratory. And in about a year, we had a meeting. After we demonstrated stability to ourselves, we had a meeting with FDA, and they indicated to us to proceed. We could proceed with a phase 2 trial, which we did. But it was very difficult to enroll the phase 3 trial. And eventually we ran out of money. It was just too hard it was too difficult a clinical indication for a small company to successfully commercialize. I was doing most everything. We had a very small staff. And so I left. But when I was working up in an engineering company in New Hampshire called Obit Systems, I was hired to develop another chemistry, an iodine-based chemistry for another company, which I did. That company is called Iotech International. They're now doing quite well, selling a mouth rinse that is very effective, again, for periodontal disease, but also for patients who have oral mucositis, chemotherapy patients who are undergoing therapy and have oral mucositis. And at the end of when we closed down that initial company, some people licensed, including someone you're familiar with, Diane, licensed some technology, and we formed a company out on the West Coast. We had some funding. And that company has led to I2 Pure. And I2 Pure is making compositions that have high concentrations of molecular iodine, and they'll be coming out with their first product in this first quarter, which is a wound rinse, a sterilized iodine-based wound rinse that will deliver high levels of I2 to wounds. And over the 30 years of working in the area, I've published a number of manuscripts, some of which are in support of products, some of which are science, just because of what I saw was gaps in the literature. We just still gaps in the literature. I just published 2 or 3 manuscripts, those relating to topical disinfection as opposed to the Iogen tablet, which is a very different kettle of fish. That's a much more complicated area, complicated question, because that's a systemic effect, which naturally is difficult. But in that process, in going to FDA, they did echo back to us in the minutes of their first pre-IND meeting that the science that is established in this area and that molecular iodine is less thyrotoxic than iodide. And in the PhD thesis, which Carla Thrall published, her conclusion basically says, look, molecular iodine is not only less thyrotoxic, but it has very different pharmacological properties than iodide. So these two things are clearly not the same, something that any first-year organic chemistry student at any university in this country would be able to tell, would be able to say. But because physicians have 2 centuries of experience using iodine clinically, there's a lot of misinformation in the medical literature. I mean, if you even look, when you talk about table salt, you say sodium chloride. You don't say chlorine. Yet somehow, when we talk about iodine, nutritional requirement for iodine, it's not iodine, it's iodide. That's what you get taking. Iodide is the nutritional element, not molecular iodine. And so, yet that seems to be accepted and standard. So there's a pervasive cognitive bias on the part of physicians when they think about iodine. Very few of them understand topical iodine chemistry. I won't hazard a guess. It's very low. And many of them just are not interested in iodine system, the iodine biochemistry outside of thyroid hormone. However, thyroid hormones are one aspect of iodine biochemistry. And then there's other things which encompass iodine biochemistry, which may not have primary significance for clinical practice, but they may be very real effects. And some of those women who traveled every 6 months up to see Dr. Gent knew that firsthand. Fortunately for me, although we never worked directly with each other, while I was reading the literature and how to respond to FDA over those years, they have all these questions, these god awful long documents you have to write. And there was clearly gaps, but when you look in the literature on iodine, what you'd see, I mean, the way I thought of it, which is politically correct, is every 6 months, a middle-aged, white, very smart physician would write a review article on iodine. And it would be written beautifully, and there'd be nothing inaccurate, but it did nothing. It advanced nothing because they were doing a literature review, and they thought they were doing something. Then along came Carmen Sieves and began to advance the field based on creative experimental designs. And she's now, it's more than 2 decades later, and she's really lifted the field dramatically for those who are willing to read, and demonstrated a wide range of, provided a lot of evidence to demonstrate these other effects, these extra thyroidal effects of iodine, anti-proliferative activity, just a range of non-thyroidal biological activity associated with iodine. Does that mean the medical community will pay attention? No. They marched to their own drummer. But eventually in time, with science, eventually in time, and now there is some other people looking at the area. It'll be slow, it'll be painful, but eventually they'll begin to teach in medical schools the difference between iodide and molecular iodine. And hopefully the physicians will be a little bit more aware, because the physicians can't think correctly. They spend their time inefficiently. They don't, when they design experimentation, they're not in a good place to do that. And patients suffer because patients have died because of physicians' lack of understanding of the chemistry of povidone iodine. It's that simple. It's not more complicated. And that's a rather blunt, obvious endpoint, but I'm sure there are many more subtle impacts on patients.
So I want to, I mean, this is all fantastic. I love walking down memory lane and iodine with you. But I want to take us back to the development of Violet and at that time with the study. What were you and your colleagues looking at? What was the problem you wanted to solve? What happened in those attempts to solve that problem? And then what became the end result?
So the first problem we had to solve was to develop a stable oral dosage form of molecular. And we did that with using two food additives. And there were other problems to solve to make a tablet stable, but we eventually did that. And those tablets really have excellent stability. That was number one. Number two, the prior company had already provided FDA with a lot of anecdotal data and human clinical data, human clinical safety data. And the challenge is to define. So you don't have an indication right now. There's not an indication for clinical mastitis. What is it? Is it 7 days a week? Is it 5 days a week? Is it 14 days a month? So we don't have a defined indication. That's a challenge. Do we have a tool that we can use to measure it? We don't have a tool we can use to measure it. And we have at least 50%, if not more, of the physician population who never experienced. They don't have an idea what it is. And the majority of the other this staff population of physicians don't experience it either. They don't have a way to measure it. They don't have a definition for it. They don't have a treatment for it. That's a problem for the patient who has a serious case of clinical Mastalgia. They've got nowhere to go. So there are a lot of clinical challenges in terms of developing that indication. And you have to get a group of people at FDA to agree and doing something new, which is an unpleasant task. You better be very patient and have a lot of time. So and then you have to recruit. You're running a trial, you finally get to an endpoint. What's the level of pain reduction? What's the definition of a patient? What's the level of pain reduction, which is clinically meaningful? So on and so forth. We finally get to a trial, and now you have to find patients and recruit them. But these patients, again, don't have a home. There's no categorization, so it's very hard to recruit them. Not like you can go to a breast pain specialist here, there, or anywhere. So it's a real challenge to develop a new indication for clinical mastitis for all of those reasons. And in the UK, they really, for some time, I don't think they have it any longer, but for some time, there was one breast surgeon, Robert Mansell, who took an interest, and he's influential. And it's a national system, not independent. So they could focus on patient well-being, not economic well-being of the entity they were working for. So there were a number of different breast pain clinics in the United Kingdom. And the first thing he did was make measurement. Shocking. So he sent patients home with diaries, and they charted their pain every day for 3 months. And if that patient had severe pain for a week or more, then they would consider treating. Unfortunately, the only treatments they had were hormonally based. So that's not an ideal situation because it's a chronic condition. You don't want to you take a 20-year-old girl and start putting her on hormones. The only one who thinks that's a good idea maybe is Robert F. Kennedy Jr. I don't know. So it's a problem. And we don't have a good treatment for the indication. But there certainly are patients whose lives are dominated by this pain. And unfortunately, they really have nowhere to go, which is why Dr. Gant had such a large patient population traveling to him up in Ontario, Canada for such a long time. It's like 10 years worth of data that he collected. I think it was close, 923 patients. Some of whom he was treating for, when I say some of them, over 500 of them, he was treating for more than 5 years. Mm-hmm. So he had a reasonable population of patients. The
Do
other
you,
thing about yeah, go ahead.
no, do you feel like from the beginning of that study time to current day, do you feel like the indications of breast swelling, tenderness, pain, all of the things that women come in describing, never with a actual diagnosis, but just symptoms that they're feeling, do you feel like that continues to exist in today with
Oh,
today?
yeah. I don't know, but I would suspect it's worse because I'm not working in the area anymore.
Why would you
Because,
suspect that it's worse?
because we have the rise of larger healthcare organizations,
Mhm.
fewer individual physicians. Yeah. And medicine has changed. It's more, they rely on diagnostics more than they did back then. And there is no diagnostic. It's no diagnostic. So if they can't measure it, it doesn't exist. It's a real challenge for those patients. I don't know how else to say it,
Yeah.
you know.
We
Right. But
we hear it frequently from our customers or the individuals who are part of our community, and it is the individual who, by most of our, I would say, that are self-diagnosing, they're going online, they're putting in their symptoms, they're looking for a solution versus the doctor saying, "Take an Advil and I'll see you in 6 months," kind of deal. And women are tired of living with the pain. They're tired of not missing work, not being able to do their normal routine, having to give up working out, all the
there's,
information wearing a
there's
bra.
no way they should accept a response for some guy who, or some woman who tells them they don't have. I mean, that's not the way it's supposed to work. They're supposed to listen. There's a conference I remember, I never forgot it. Mansell is at this international conference, and this American surgeon says, "We don't see that many patients with breast pain." That's what he says. And Mansell says, "I think you see them. It's just you're not aware of them." He says it very nicely,
Right.
but there's no excuse for some asshole not listening. I mean, it's not more complicated. It's not more complicated than that. And they shouldn't allow them to get off the hook by being polite. I wouldn't. You have pain, you go in there. Some person who's not experienced the pain tells you you're not having pain. There's a easy answer for that, and that's to get right in his face and challenge him. It's wrong. That's not the correct response. Now from the physician standpoint, they have nowhere to go, but that's not an excuse. That's not.
So it does fall then on just education, which educating the physician, you're educating the healthcare practitioner, whoever that might be, because we have so many functional practitioners now or naturopathic physicians, and they tend to be far more informed around iodine and its relationship to breast health. So that's kind of a nice segue into just if you'll take a little bit of time to just talk about what is happening in the breast tissue that one, what is happening in the breast tissue,
No,
and two, why is it and what is it about specifically molecular iodine, because that's what we're talking about today. How does that address what's going on in the breast tissue?
I hadn't thought about that for a long time, and I haven't followed the literature, so maybe things have changed. But the only manuscript I read, there was a series of manuscripts that tried to understand clinical nostalgia. And we have to draw a distinction because there's non-cyclical and cyclical clinical nostalgia, and non-cyclical clinical nostalgia, breast pain not associated with the menstrual cycle, has a different etiology.
Mhm.
So in the UK, they would treat that with a very strong hormone, which it's a mascularizing hormone, basically, danazol.
Mhm.
And cyclic nostalgia, they treated it with tamoxifen.
Mhm.
But if we look at cyclic nostalgia, which I think is the majority of the cases, there's at least a hint of an etiology. There was an initial study by Mansell, and he demonstrated that in those patients, if you examine them, if you examine what's known as their stimulated prolactin response. So it's a very difficult test. You have to sit in a chair, they inject a hormone in, they have to draw blood, look at the prolactin level. But in those patients, there was an atypically large pulse of prolactin. And so if they used a drug or a therapy, if there was a German physician, Friedrich Peters, who looked at a number of things and he mitigated the prolactin response, and you saw their breast pain being reduced. So the only information we have, I hesitate to use the word the best, but it is the best because it's the only, is that the condition is associated with an exaggerated prolactin response, pulsatile response. I mean, of course, you see physicians then go in and draw blood and say, oh, no, they don't have an exaggerated prolactin response. You have to examine the breast tissue itself, which is getting hit with a larger pulse of prolactin, not draw blood peripherally after the prolactin's been mixed in the body 5 times. I mean, ridiculous. But there are several studies, and Friedrich Peters did some of them that made an attempt to look at those patients and look for measurements that validated and increased the biological activity of breast tissue associated with this large prolactin release. It's been a while. I haven't looked, but there were a number of studies that did that. Rose at Valhalla Medical did a study showing there've been like 3 or 4. You have to appreciate that no one looks. They're not interested. It's difficult to make the measurements, and they're not interested. There's no incentive for them to look, so they won't look. But that seemed to be a reasonable place to start. If you were going to start based on evidence, that would be where you would start.
So we increase of prolactin, which
So
causes the symptoms,
yeah,
and then
increased pulse. So the total amount released may be the same. I don't know, but the pulsatile release was much larger. The pulse of prolactin, which came out, was much higher. Then that may be stimulating the breast tissue, which in turn may lead to the breast pain, growth of some atypical tissue, nodules, and then breast pain.
so specifically, like what does, in our case, I mean, we're talking molecular iodine, but specifically,
Oh,
how does that address what's going on in the breast tissue?
so let me take you in another direction initially, because it's hard for doctors and a lot of people to think of when they think of iodine, the only thing they think of is the hormones.
Mm-hmm.
That's it. Yeah, that's it. That's the beginning of it. Why do I have to know everything else? I can call everything iodine. I don't have to know a damn thing. And they don't. So very soon there's going to be a trial result released where patients who had a serious stroke. So you have a stroke and there's a clot there, right? A clot sitting in the blood vessel, and they want to perfuse the clot. They want to get rid of the clot. So you want to flow some saline past that clot. Well, there's risk associated with that, because now that you're trying to get rid of that clot, if it's too turbulent and you just rupture the clot off, you can create a little hole in the side of the vessel, and it's not good. These surgeons at Harborview Medical up in Seattle, top notch, just an absolutely excellent university, had published looking at animals and demonstrating that high levels of iodide helped greatly in terms of preserving the homeostasis of the animal in like hibernation. It was a clear biological effect from iodide, not from thyroid hormones. So they took patients and ran a phase 2 trial, patients who had a serious stroke, and in the perfusion solution, they added a great deal of iodine. So now you have a high concentration of iodine. They compared the control group to the iodide group, and they showed clear clinical outcomes. The iodide group had smaller diameter holes in the lining of the vessels, and they were better off clinically. They ran a phase 3 trial with like a couple of thousand patients, I believe. We should see those results soon. That's not due to a thyroid hormone. That's due to iodide, okay? What's happening there is likely. So you have this clot, you have inflammation there, you have an enzyme system, a lot of biological material, but myeloperoxidase is probably there. You now supply iodide at a high level. That iodide is converted to molecular iodine, reacts with arachidonic acid, lipids in the area, which are anti-proliferative. And Carmen Sieves has demonstrated that in 10 different ways, 15 different studies. So if that drug is approved, if the results are positive, it'll help not only the patients, but there's a fair chance it will benefit the thinking of physicians, because now all of a sudden, here's a therapy, a pharmacologic therapy. It's iodide. It's not thyroid hormones. It's iodide. They're very smart. They're smarter than I am. So it won't take them too long to begin to realize this is a more complicated story than what they've been thinking. In our case, the overwhelming likelihood is that the molecular iodine is forming 6-iodolipid, which is coming to the breast tissue, acting as an anti-proliferative, which we know it is. We've demonstrated it is. It's the active agent. It's the reason. It's a causative agent in the Wolff-Chaikoff effect, where if you start swallowing large amounts of iodide, your thyroid reacts and slows down. This auto-regulates. And the reason for that is the 6-iodolipid is an anti-proliferative, and it just shuts down your thyroid, the synthesis. So that's likely what's happening in this case. And we know that if you look at breast tissue and you look at pregnancy, we know pregnancy is protective for breast cancer. What happens in pregnancy? You start sequestering a lot of iodide in the breast tissue. You upregulate lactoperoxidase in that breast tissue. We're making a lot of a lot of molecular iodine. Most of it, the molecular iodine, is going on to albumin for delivery to the neonate, but that system is now turned on, and it's likely that's the reason why pregnancy is protected from breast cancer. Yeah.
So there are a lot of options for taking iodine on the market. You go to any supplement store and you'll see a wide variety.
There's
And
only one. Yeah. The FDA said to me, wrote down on paper, which is not easy to get them to do, that molecular iodine is less thyrotoxic than iodine. Okay.
why?
So when you look at the safety profile of iodine, the only concern is the thyroid.
Mhm.
That's it. So if you're taking iodine, you want to take molecular iodine if you can. And there's only one stable dosage form of molecular iodine that's ever been developed. So the other dosage forms have very high levels of iodide and very low levels of molecular iodine. In fact, even if they feed molecular iodine to you initially in the form of molecular iodine, it now has to go to your stomach. It'll be absorbed in your stomach, but it's got to survive long enough to get down through your esophagus, your mouth, before it hits the acid in your stomach. And molecular iodine reacts pretty rapidly with organic tissue. Probably never makes it.
Mm.
That's not to say there wouldn't be some benefit in some patients, because that iodide can then further be oxidized down the line. But by providing pure I2, you minimize any toxicity and you hopefully maximize benefit. So the therapeutic index should be much higher.
A woman starts taking violet molecular iodine, all blood levels, TSH levels, everything's looking really normal. Blood profile is looking really normal. Start to take molecular iodine, and all of a sudden the TSH levels start to rise. What is that an indication of, or what may be happening there?
Yeah. So first off, when we did those trials, what's the signal? What signal did the FDA want us to use as a safety signal? TSH was the only thing they were interested in. They were not interested in anything. Same thing, Lou Braverman, he said TSH. Lou Braverman said a cutoff of 10. The FDA probably said a cutoff maybe 30, 70% of that or something lower than certain. So if you're euthyroid, you have a healthy thyroid, and you have no previous history of thyroid condition, generally should be not a problem. I mean, that your thyroid adapts. That's the way it was designed. But there are patients which they refer to as subclinical. They have subclinical thyroid conditions. And by being exposed to high levels of iodine, you can unmask some of those subclinical conditions in some instances. Okay, so that may be what's going on in some cases. If their TSH is elevated, it may not be meaningful at all unless it gets beyond a certain level. And I'm not the right person to ask what that level.
Because there's
Yeah,
a lot of other contributing factors that need to be looked at specifically with your
right.
physician who's following your particular health profiles.
But it's sort of like it's a shitty situation in the sense that the international you have to set a level. So we have the goiter belt in the United States, right? So we have a lot of goiter, and they figure there's an iodine. They finally figure out there's an iodine deficiency. So the International Organization of Medicine gets together and they're going to set a level. Unfortunately, they've got like 10 endocrinologists sitting around a table in 1920, I think it is. That is not what you want. Maybe 2 out of the 10 can be endocrinologists. It's a multidisciplinary challenge. There's things that you don't understand. So these 10 endocrinologists naturally are looking right under the lamppost at everything they understand. So they set our level at 125, only what the thyroid requires. So they probably screwed generations of patients because there are extra there's roles for iodide outside of the thyroid gland. And we're not feeding that. Once you condition a large population to consuming low levels of iodine, now you have a real challenge elevating that concentration. So there's this famous case where they go to Africa, sub-Saharan Africa, they're deficient in iodine. And these docs when they want to do something for these patients and they inject iodized oil. The theory and in practice, so you put a lot of iodine, it's like a contrast agent. A lot of iodine in a large organic molecule partitions into the fat in the body, and gradually that molecule breaks down over months, years, and releases iodide into the bloodstream. Well, this whole population has been iodine deficient for God knows how long. And so now they've created a firestorm of thyroid problems. And it's not so easy to get because you have this source of iodide inside their bodies constantly releasing iodide. Sounds like a nightmare for them. So once you condition the population to be iodine deficient, it's hard, very hard to elevate that level. What would be a healthier level in the United States? Probably almost certainly 600 rather than 125. And what you see in the literature in 1962, this researcher Pennington from the FDA did a beautiful study of what's the upper limit of iodine that you can take daily, the safe upper limit. And she reviewed the entire literature, and it was 1.1 milligrams per day. And every 6 years, 10 years from then, someone would hire a toxicologist who would do a beautifully written study citing all the same literature and maybe a couple new publications, wave his hands in the world and lower the level by about point 0.2 grams. It's like a joke. It's like a bad joke. I don't know what to say. So their ignorance, it's not quite fair. That's harsh. The lack of criticality of understanding the role of iodide and paying attention to it has led them to ignore it. And we're now in a situation where we have pretty low levels of iodide in our population. And it's not easy to fix. And it's even harder to get them to discuss it and be very hard to get them to change their minds.
So that's a great way to kind of lead into, because I do want to talk about how you arrived at the dosage with that, because we really talk a lot about give us 60 days, 60 days, 60 days.
Oh,
How
you
did
need
we,
time.
pardon me?
You absolutely need time. Yeah, first off, it's a condition associated with the cycle. And so you need a couple of cycles in order to interrupt what's going on, at
Menstrual
least.
cycles.
Yes. Yeah, absolutely. And that's the nature. It's chronic condition, and you're going to need time to do that.
So we have women who write in and tell us that after 7 days, it's amazing the amount of relief that they receive. Some women at 60 days, like, I've had I've experienced zero relief. So what is your response to either one of those women?
I'm sure they're both right, and like a lot more data points. Typical scientific response. You can't. How can you contradict a patient who's reporting on their pain? You can't. You can ask them to report more data, but you can't tell them they're wrong. Only if you have a medical degree from Harvard or Johns Hopkins can you tell them they're wrong. Then you can tell them they're wrong, and hopefully they turn around and smack you across the face. But it is what it is. They, it's entirely possible because we can't see into the baseline biochemistry of the different patients. We don't know what the fact is. It's just so very difficult.
So how about we also talk a lot about the need for consistency. Well, why is it important? I mean, hence Violet Daily. Why is it important when women have potentially a pretty deep pain system? Why is it important for women to consistently, and
Yeah.
what are the other parameters around taking Violet that
Yeah.
are important?
Yeah. Because it's a pain medication as such. It's not acting to nerve endings or anything like that. It's changing something that's going on structural. It's interrupting an unintended biochemical pathway, and it's doing it slowly. So if you're not consistent, you're going to have a problem. What's an analogy that we can drum up? It's like you have a pond with a gateway. If you don't keep that gateway closed, you're going to lose a lot of water. As soon as you stop, you're letting that water begin to flow out of the pond. You're sort of holding back this pathway by
Mhm.
taking it daily.
So let's shift gears a little bit and talk about what are other benefits? Obviously, the work that you initially did in the development of Violet, which came to be known as Violet as a today on the market. What are other bigger and broader benefits to potentially taking molecular iodine?
That's an interesting question. I've never thought about it. So Carmen Neceves is running and had started a number of studies down in Mexico as a preventative both for breast and prostate. And when you look in the literature, we see that famous association, that famous study where you have a very low rate of breast cancer years ago, decades ago, in Japanese women. And when they come to the United States and change their diet, their rate of breast cancer normalizes. Okay. So they go from a high diet, perhaps a lot of fish, perhaps not a lot of meat to the United States, to a low iodide diet, more meat, and their rates of breast cancer normalize to the rates that are here in the state. There's nothing that says two things. So it's amazing when they talk about toxicology. These analyses conveniently forget the high levels of iodine that Japanese people consume. Of
Mhm.
course, evidently they're Japanese, so there must be something unique, different about them, which is not the case because we take the person, we take those women, bring them to the States, change their diet. There's nothing unique about them. They've got the same genome, the same everything. It's an interesting question, and I don't see, honestly, I can't remember. I'm not a physician. I don't really think in terms of speculating about something like that. And I haven't read anything where they speculate about potential benefits. It's all negative when they think about iodine. It's amazing, isn't it?
It is amazing.
I hadn't thought about that. That's pretty interesting. It's all just like Everything is totally thyrocentric, like 1920 all over again, setting the iodide level. There are probably a lot of benefits, although I haven't seen speculation on it. I think we're definitely iodine deficient. And I think it's hard to escape from the fact that we're iodine deficient because we have a lot of cognitive biases on the part, certainly on the part of endocrinologists, entrenched cognitive biases by extremely talented, very educated, influential professionals. And then just the medical industry in general, they don't teach this distinction in medical school. So until recently, I only saw recently in Wikipedia for the first time like an overview of thyroid, how iodine gets onto thyroid hormones. Thyroid hormone synthesis, pretty basic, you'd think. But they didn't, when I was doing this, I read the literature when I was working on this. I read the literature. It was like, they're telling me all the stuff. They don't even know how iodine gets on the goddamn enzyme, which they ain't. So it's only recently I saw the first in Wikipedia, the first overview of something that's consistent with what we call science. Sorry, guys, that's the case. And it's a real, it's an, it's amazing. It's a miracle. The thyroid gland makes these unique spaces that contain only the things necessary to make thyroid hormones. It takes thyroglobulin, peroxidase, hydrogen peroxide, and it's get pushed into this little space called the follicular lumen, where the first thing that happens is iodide gets oxidized to molecular iodine, and then it just diffuses around until it chemically iodinates thyroglobulin. It's not an enzymatically controlled reaction, it's a chemical reaction. And so we have this, it's like a chemical reactor, a hotbed of chemical reactor. There's a lot of free radical chemistry going on. There's iodination going on. So it's moving around in there. And there's a lot of, that's something I think that should get taught. God knows what the young students would come up with if they actually understood that chemistry. I'm sure they'd be better. They're better off understanding than not understanding. For decades and decades, it comes in and then the magic happens. It basically is what they were saying. And admittedly, it's difficult for them to reach that because they can't get clear empirical evidence. I did publish a paper with no less than Christian Obinger, he's the leading expert ever on mammalian peroxidases, and Jeff Eales, who was sort of the grandfather of comparative thyroidology. And Christian Obinger demonstrated that the enzyme peroxidase cannot possibly have a tyrosine molecule from thyroglobulin come into the active site of peroxidase. It cannot happen. So if that can't happen, then what happens, there's only one other way it can happen, and that's for us to make I2 in that follicular lumen for it to diffuse over to thyroglobulin, and either I2 or hypoiodous acid is iodinating thyroglobulin. It doesn't seem too controversial to me. I'm not sure why they're resistant to teaching. Maybe before I die one day, some of them will do it. I don't know.
I'm
But
hoping at the time, Jack, that we're going to see things really change with iodine. I want to circle back again to the dosage that you arrived at for Violet. What was that based on?
that was based on, so when Gant dosed his patients, he dosed anywhere from 3 to 18 milligrams per kilogram. Okay. And when I went to FDA, we initially asked for 3, 6, 12. The FDA had already seen all the data from Patheon. They knew you didn't have to go higher than 6 milligrams. They knew that. So they limited us to 1.5, 3, and 6. That's basically where it comes from. It comes from all that work that Gant did for many years. Yeah.
Is it beneficial? Can women take the tablet, and if they're feeling uneasy about that dose, that it's too high or their physician is telling you that's too much iodine to take, can they cut that tablet in half and still receive benefits?
Yeah. So if it was my mother, I'd probably have her take half a tablet. So if we take a quarter of a tablet The tablet's 3 milligrams. It's like 700. That would be 750 milligrams. So a long time ago, Braverman did a study and asked the question, what level of iodide, daily iodide, is required to perturb TSH, just to cause it to change, then some response. And if I remember correctly, I think it was 750 milligrams. So there's nothing wrong initially with cutting the tablet in half for a week or two. That's fine. It gives you it because you have the Wolff-Chaikoff effect will kick in over that period of time. Your thyroid will have adapted to higher levels, and now you can go to 3 milligrams. And the half-life, once you swallow the tablet, the half-life was about 6.5 hours, if I remember correctly. Yeah, something like that. In theory, you could take it twice a day. That would
Oh.
be okay because you just want to take it on an empty stomach. That's all.
And never crush and never chew.
I wouldn't crush it. No, I don't think there's a benefit. And I don't think there's a benefit in chewing it. It turns out the way the chemistry was put together, if you crush it and just swallow the powders, it's fine. It's going to be stable. It's not going to do anything. It's not going to be a benefit because what has to happen is that I2 isn't formed until it's in the pH 1 environment of the stomach. And the way the tablet is made, the right ratio of iodide and iodate is homogeneous throughout the tablet. So when it hits the stomach, I mean, when you put it in 1 normal hydrochloric acid, you see the metal form. It forms like that. It's diffusion controlled reaction. So I don't know. I wouldn't powder it. What you don't want to do is powder it and then put it in like applesauce because applesauce is acidic. Yeah. You don't
Um,
want to put it in, you don't want to put it in acidic. If you can't swallow it, you want to powder it, put it in cottage cheese. That won't be wonderful because now you're taking the tablet with food. So
exactly.
yeah,
Exactly. It's sort of
yeah,
counter to that
yeah.
idea.
Right.
Mhm.
Yeah.
So
So
if the tablet is taken, and let's say a woman takes it for 30 days and she feels like and or she goes to her physician because she's having some kind of symptoms, or maybe it's just time for her routine blood work. Her TSH goes up, or maybe they're just experiencing itching or some kind of honestly, there people will write in with really interesting symptoms, which I never say, "No, you're not feeling that. No, that's not possible," because anything's possible because I don't know your full
yep,
history of
sure.
everything that you're dealing with. But how does does the tablet or the amount of iodine that they've ingested in the tablet, does it remain in the body? Is it eliminated, what's not needed?
Half-life, 98 point something percent was eliminated in urine, the majority of it. And again, like I said, the half-life was 6.4 hours, if I remember correctly. So it's rough. You lose 50% every 6.4 hours. So at 2 days, you're down. 5 half-lives, you're down pretty far. It's readily eliminated. That shouldn't be a problem. And there is a publication on the safety effects of iodine from chronic dosing that was published in the Handbook of Iodine and Chemistry that I wrote, and it has all of the thyroid function tests for hundreds and hundreds of patients over time. So there's actually reasonably good data out there that they can look at. Unfortunately, it's in a big fat book, a reference textbook, but it has data from one study, one 5-year study with over 523 patients being dosed up to primarily with 3 and 6 milligrams daily for 5 years. There's other studies, 6-month studies, a number of 6-month studies. So there's reasonable data out there to look at to get a feel for what's going on. There is no such thing as an iodine allergy, but There is something they refer to as iodism, which is very interesting. There was one patient in Texas, and she developed a rash on her arm. So they broke the blind, and she was taking 6 milligrams. They broke the blind and they withdrew drug. They waited a couple of weeks. The rash went away. They re-challenged with the drug, and the rash on her arm came back. So that's a real phenomenon. It's not a, it's not an antibody mediated phenomenon. It's really interesting, and no one has speculated about it. It's just not interesting to anyone. But I find it really interesting. I just wonder what the mechanism of that is. That's so odd. What's going on there?
Yeah,
I
and
don't know.
you would almost have to study it over time and multiple women having the same thing, and then what are the
Yeah,
correlations between all of those women? Because it could just be something in her own makeup that when you look at in singularity. So you continue to work in the field of iodine. So what's
so
happening? What's exciting? What's coming up?
so we're doing, yeah, so we basically work in the area where we're making products that use molecular iodine, high levels of molecular iodine. So what's coming up shortly is I2 Pure's going to introduce a new wound rinse that will have high levels of I2. So today, not everyone, but some surgeons that they have figured out, they're so good at what they do. They figured out that if they dilute povidone iodine, one to what they have different protocols. They don't know the best way to do it, and they don't make any measurements because they have no idea how to do it. But if they dilute povidone iodine, and they use it as a wound rinse, they get fewer post-surgical infections. They seem to be, yes. So they're doing that. They call it Texas T. And we just gave a presentation. Dr. John Meehan gave a presentation at the annual hip and knee surgeons convention in Dallas about 3 months ago. We made measurements for him, and he presented the data explaining to them how they should do this, what they're getting now. So they dilute it in saline, they dilute it in water, 1 to 30, 1 to 35, 1 to 100. We made the measurements to show them the different levels of iodine. They can't let it sit around. If they let it sit around, they won't have iodine. So the best they can get now is about 15 parts per million. So we'll come out with a product that's it's sterilized. They don't have to dilute it. It can remain sterile as it sits in the body, and they can just squeeze it over a wound, and it'll have at least 4 times the level of molecular iodine than their dilution. But more important than that is this other thing about povidone iodine, which the people who develop povidone iodine, there's 10,000 parts per million of titratable iodine. There's 1 part per million of I2, one in most commercial products. We've measured it, so we don't have to speculate. There's 1 part per million. But it's a big reservoir of iodine that can deliver to you. We also measured for the first time, we just published, the release of iodine, the ability of an ionophore to release iodine in response across a hydrophobic environment, meaning skin. But povidone iodine doesn't release iodine. The product we put together has the ability to release iodine very readily. So we can probably release, I can't remember what the number was, but it was over 70% of the total iodine that we had in. So it's not just that we have an initial level of 60. We have a truly dynamic system that's able to rapidly release higher levels of iodine if it's required in response to a bioburden. So those are two meaningful changes, meaningful functional changes to the topical formulation. So that'll be the first product that we come out with, but there's a number of other things that we can work on, that we are working on. So hopefully, I'm hoping that clinical study out of Harborview in the heart patients, the abbreviation that's STEMI, yields positive data. I think that would have a meaningful impact eventually on how physicians think. Because these guys are very smart, very well trained, serious professionals. It's the mother of all cognitive biases. It's just like Yeah, and I have to write a manuscript on that. I'm tired of writing manuscripts. But yeah, I will. If I get motivated, I started to collect some information. I'll start to try. That's the only reason I could draw the analogy between table salt and iodide initially, because that's the lead in. That would be the lead in. And it's sort of like a good lead in because, yeah,
It
why
is.
the hell, why are you calling this chloride? You're calling this iodine. It's not iodine. What gives? It's this 200 years of clinical experience with Lugol solution, povidone iodine. This is iodine. And on top of that, they've never been able to isolate a role for iodide. That's why I think you can demonstrate, comes a drug, and you can demonstrate that iodide has a clinical benefit in these patients undergoing perfusion, stroke patients undergoing perfusion. Then I think that will help a lot because they'll stop and think. Once they start to think and they get out of the previous thought channels, they'll be fine. They'll be telling me about it, explaining it to me. But I'll tell you, having a physician like John Meehan on board, and he wrote a beautiful manuscript on povidone, how it works, what it is, why we dilute it, so on and so forth, is a big help because they will listen to another physician.
Mhm.
Doesn't mean they'll adopt immediately. He's very credible. He's a professor of osteopathic orthopedic surgery. They will listen. He's smart as hell. So it's a pleasure to let someone else speak.
Jack, I want you to leave our community with a little advice from Dr. Kessler, who's been working with iodine for so many years. What do women need to understand in the relationship between breast tissue and iodine? What do
They,
women need to understand?
yeah, they really need to do their own work. They really need to take care of themselves. And they probably need to educate the physician they're working with. If it's a good physician, the physician will listen, engage in a dialogue. And if they hear some physician who starts talking to them, find another physician. You see, you're wasting your time. There's not at this point in time with you when I talk about this stuff. I don't care who the hell they are. I don't need to read something to learn how to think about iodine. I do experiments so I can convince myself one way or the other. They're in a place where they read something and they regurgitate it back. You know, it's not exactly overwhelmingly impressive. Anyone can do it. But so they really need to be their own advocate. I don't think they have an option.
I agree.
Mm.
Advocacy, you must advocate for yourself. Oh,
Yeah.
any other final comments before I do a quick closing here?
Yeah, nothing else. I can't think of anything else.
Okay. So I'd like to thank you for your time. I obviously want to thank you for all the years of work that you've put into
Yeah.
iodine and the development of a product that is truly changing women's lives. They're
Yeah, I will say that we were very happy with that formulation because the other group, the formula is just constantly changing. That formula is absolutely rock solid, very stable formula.
extremely stable.
So yeah,
Continue to get it tested, and the stability continues to maintain. I mean,
before we went to FDA, we made several batches and stressed the stability, and it's over these last couple of decades, it's proven to be very stable. That that's
I
nice.
thank you for helping me help other women. I really appreciate that.
I
I
can
mean,
say
you heard it.
same thing here.
You heard it from Dr. Kessler. You must advocate for yourself.
I
So,
don't think I don't think they have a choice.
mhm.
I can only imagine if I went to the doctor and the doctor told me, "No, you're not thinking this." It would be quite a conversation. It would go downhill very fast. I'd be right in his face. Why not? You can do it nicely, but
Sure.
you don't want to listen to any bullshit.
Yeah.
Bullshit is bullshit no matter who it comes from.
All right. Ladies, I want you to remember to advocate for yourself, drink lots of water, do something kind for others, and be sure you are one of those others that you're taking care of. Thank you very much, Dr. Kessler.